Okay, we had imagined that from the each of the tables, we would have a question or so for our panel, and we wanted to take advantage of their expertise while we had them here, and all this information is fresh in your mind. The problem is I don't really have your questions. So that puts the regional chairs in a bit of a spot, because I'm going to ask you in a minute or two to come forward with a question or something for people to reflect on up here in a couple of minutes. But in the meantime, I will ask a couple of questions that I'm curious about. And one of them has to do with how will care management be different in the future than it is now, in the sense of management of what the professional does. All right, so we're used to seeing it in the past coming from a third-person entity we didn't often know, who we talked to on a phone to authorize care and to do other kinds of things. How do we imagine that system is going to be either similar or different in the next, say, 10 years? Okay.
We have a course about care management, so I felt okay about piping up. One of the things that reasons we created it was because, as I said before, care management or case management is a common role, and it has been a role that was in either one of the silos, and very few people were comfortable working with a complex patient who had multiple complex needs, and being able to do the care manager is to some degree the glue that engages with the patient and helps them be connected to the care system and helps them not get lost in the care system. And to do that, that takes a level of behavioral activation and engagement skill that is more than just driving people around, but they need to be knowledgeable enough about medical illnesses to at least be the eyes and ears of a medical treatment team, whether or not they are one of the medical people on the team. And the way of organizing this that has seemed to me to be most useful is that teams are made up of expertise and they're made up of bodies. And if you don't have enough workforce, that's not going to do it for people with very complex needs who don't come in a lot and aren't activated about their own health care, activated and empowered and enfranchised with enough income. But you can't have all of that expertise, both medical and behavioral, in any one person. Early on in family medicine, they thought, we will train these family doctors and they'll have all this expertise. And so if you look at one of your advisory group who isn't here, Frank Degree, Frank is a preeminent family physician. He is an excellent psychopharmacologist. He has a master's degree in family therapy. The guy is a whole team in himself. But he's kind of a skinny team. He's really just one guy. And so he is one of the leading advocates for we need more people on the team. For I don't want to and can't do all of this. We need the behavioral health folks. We need these other folks. And when we've had times when our system was working, which has varied, we've had the behavioral health folks and the care managers and the physicians, not all of them, but all the care managers, most of the behavioral health clinicians in a little group of us, 4 practices, and a couple of docs, and we met weekly and we talked about challenging cases. And being able to have the expertise brought to bear on the more challenging cases to help when what we usually do first doesn't work. I mean, we have things we do first in our system, right? patient teaching and more meds. And when that doesn't do, then we have to think of something else. And one of my concerns is there is now good evidence that non-licensed people on the care team add value. So healthcare workers, promotores, people from the medical assistants get trained. All of those folks, if you start with any team and you add them, you will have good outcomes. We have the advantage of having a system that's so terrible that darn near anything you do gets better. And so that means everybody's got evidence for their flavor of non-licensed person. And they have people who are starting to advocate for, why can't we fund this flavor of non-licensed person? And HRSA is looking at that. And I'm concerned that they'll think, well, look, these folks are so much cheaper than getting behavioral health folks. And they do add value because look at these studies, so we'll just do that. And I feel like it's really important to look at the expertise array on that team and not to leave the behavioral health expertise not there, even if for many people, the non-licensed person does a great job and is particularly, maybe in the mental health world, the peer movement is particularly powerful because of the stigma. And so someone who says, I got it too, is someone who can relate to people, just like in our diabetes group. It's the diabetic who looks at the other diabetic and says, you see what you're doing to your family, you need to get on your diet, and you need to stay on your diet. That has a good deal more authority than when a health person does that. And that's the end of it. I got going, I'm sorry.
David, let me just add to what Sandy stated. Some of the folks that I've been dealing with, and from my perspective, is the care manager role, I think, is still being defined, as it looks, say, in about a decade, as you pointed out. And one of the things that I'm hearing that could be a good role for the care manager is actually elevating the game where, as Sandy's pointing out, the team-based approach is going to have a lot of different skill sets. But who on the team is really going to be, if you remember my slide about relational coordination, truly seeing that the team, and think about from an organizational standpoint of ensuring that the team itself is functioning well. Because if we don't have someone doing that role, we will fall back into our little silos, into our comfort zones, unless we're being pushed. Yeah, there's a lot of interrelational education that can happen on our own, but we only go so far unless someone's looking out for the team skills, so to speak. And I think the care manager may end up being that role because they're going to have the sort of the $20,000 foot perspective where they really can see, okay, since I am managing this registry of very chronically ill patients that also have physical, mental, and substance use issues, how do I keep my team informed? How do I keep them coordinating well? And so I think that's going to be a role that definitely has to be defined even much, much better than it is now. And I think as time goes by, certain of our organizations are going to put it under that cap, I believe, which isn't probably a bad one, except it will mean that that individual will have to have those additional skills. Could be a psychologist. So just laying that out there.
Okay.
So I'll comment just a little bit on care coordination. I think there's a lot of confusion about how we use terms like care management versus case management versus utilization management. And so I agree with the comments. Care coordination is the way we view care management. I think we have an extensive program for peers, and I think peers are going to be a more and more active part of the delivery system, but I think they have a specific role, which is to provide support, not treatment. And I think that distinction has to be pretty clear, or I think we're going to run afoul of a lot of different things. We see a lot of need for community workers, especially in Medicaid, that are people that are not in offices doing care coordination, but are actually out in the environment. I think the example is looking under bridges, but really in reality out in communities, going to churches, going to people's homes, going to places where people congregate and trying to engage folks. I think you'll see utilization management over the next few years change pretty significantly as we move more and more to pay for performance, which will mean, in essence, the end of utilization management.
Right. I'll just add, just because the Hogg Foundation, we're very much involved with the recovery movement and with the peer specialists and their role, and actually we're also funding via Hope was a technical assistance center here, and we partner with Dishes to have, a certified peer specialist program and training for them. And that is some of the concerns of the certified peer specialists, is that they're feeling maybe some pressure to co-opt their role, and they're not interested in actually providing treatment. I think Andrew's right about that. They have a very specific role, and that's a role that they want to play, and they know that they can be. And I think that skill set of, an individuals with lived experience who really can partner with an individual who now has come to, say, an ambulatory setting, who's dealing with major depression and maybe some other physical chronic illnesses, and to be able to look around, across the table and see, wow, you're employed by the clinic? It doesn't look to me like you have, major depression. And the person can actually go, I was in your spot at one time. One, it instills hope. They understand the entire concept of recovery and that it is a path that one takes. They also can help us as physicians to really understand what that role can be, and that skill is so important to be part of it. But I think that administratively and from a system standpoint, there's going to be that pressure to go, oh, well, these folks can take care of some of these other issues. And I think we all have to be aware of that and make sure that that doesn't end up happening, because I think it undermines the recovery concept in and of itself and the role that certified peer specialists or even peer volunteers or promotores want to pursue and are doing currently. So there's some real pressures from a budgetary and financial standpoint we have to be aware of those involved in the field to make sure that that doesn't happen, and actually keep them involved, because I think they're going to be able to help us to understand how to respond to those kind of pressures. However, like community health workers, they're kind of different. They do have skill sets, and some community health workers, if you think about the role that they play, say, for the geriatric population and taking care of folks at home or in other settings, how important that may be. The one thing I would also add is here's a group of population of folks that are already in the healthcare setting, which could be a really good potential source of actually empowering them and helping them and educating them to move up the career ladder, so to speak, because they're really underpaid. And here we have a group of folks that are already in the healthcare system, which I think we haven't utilized enough nor seen as a true resource, and just something that we could actually do internally to help CHWs actually have a career ladder.
Great.
Well, we've heard a lot, I think, today about how the financing of healthcare is not, there's not much money being directed toward helping the integration movement move along and be successful. So I'm curious about what you think the impact of that will be on this strong movement at this point. How will we see a change in the way the financial incentives will be lined up for many of the major sponsors? Or are we still going to be stuck in this hybrid system between partial fee-for-service and then partial global payments that keep fee-for-service kind of a major system? And if that happens, then it's kind of hard for me to see how the system drives much money toward helping integration.
Yeah, I'll take a crack at it. I think there are multiple obstacles. So part of it is you have to kind of start thinking about it as it's a new way to deliver care. And that not only is there not funding, but there aren't the constructs within how people recognize encounters and what they pay for. So, regulations that CMS puts out, the regulations that come out of state insurance organizations will have to be modified to recognize integrated care in a much more defined way. And in Medicaid in particular, so that encounters that happen in that environment really get recognized. And, oh, by the way, you could see your primary care physician and behavioral health person in the same day, maybe even in the same hour, and get paid for it, which is in many states is regulated not to happen. So I think there's a set of things about payment, there's a set of things about regulation, and then I think if you have the kind of data that we saw in Cherokee about what the outcomes are, I think that will drive things forward. But there are structural things in the system that make it very difficult to operate in that way and get reimbursed.
Let me tell more Cherokee stories,
Sure.
because we don't have Brenda to tell them. Cherokee is a good example of what I think happens a lot in folks who do integrated care settings anyway. It is, when you're doing this kind of work, it's not like any of us were trained to do, and you're always about figuring it out. So the idea that it isn't done that way isn't a reason not to do it. It's a reason to see if you can make it work, if it doesn't seem like a thing that would be worth doing. And have always been a great admirer of Dennis Freeman, who is the CEO of Cherokee, who, when he's working with a pay, every so many years, the payers come back with a contract. And the contract is what we propose to pay you for the next period. And he always takes that as an opening of a discussion. Most people sign it and grumble. No, he doesn't sign it. He says, now we're going to have a talk. And his approach to the payers is, I know that you care about these patients and that you want to deliver the best possible care for them, but I have to tell you, we're the ones who know how to do that. And so we're going to be a team, and we're going to find a way so that you can get the best care delivered to your patients. And where the contract wasn't enough, like in Tennessee, they had the rule against same-day billing, and all of the payers said, no, we can't do that, that's just how it has to be. Went to the legislature and had them change the bill. And he could do that because he's good friends with his other partners there. He has a network that he's been working with. He's been there since the late 70s, just making friends and working together. And the fact that he is so absolutely mission, you can't argue with somebody when it's about the mission. And he's on the mission. And so he has his friends, and they get together, and they, of course, are very supported by some of the legislators. And so they have a different law now. And most of us, when we come up against these barriers, we say, oh, man, I can't do that. No, this will never work. Dennis said, well, I guess we'll have to figure a way. And so when you heard Perinda talking about it, do the right thing and then figure out how to pay for it, that is a non-starter in most administrative organizations. You don't say that as a way to say something. No, how are we going to pay for it? Then we'll see what we can do. So I think that to some degree, things have to change, and they are changing, and they won't get to where we want to go in my lifetime, certainly. But on the other side, doing a little is a powerful taste. And physicians who get to work with a behavioral health person for a while, they really like it, and they want to do it more. And we have more and more patients who are starting to say, this is my health care and I want it. And that's coming slowly, because there isn't a word that patients call for. They don't say, where is my integrated primary care? But I think that just assuming that we're gonna move this thing a bit, and where it won't go, we're gonna figure a way, because little laws like this one thing about 2 billing in one day turns the whole thing upside down, makes things work that before weren't workable, and it's not a big deal, and it's not something that I think is particularly partisan. It's just, we can do this. This is what we need to serve the patients.
David, let me add So there's definitely movement afoot here from the state of Texas to add on what's already been said. Number one, of course, there's the Medicaid 1115 waiver that's it's already out the door. And the district projects, some of them are labeled as integrated healthcare approaches, right? Now, integration, it all depends on how they're defining it. So some of it's a little step, it's just a co-location. Other, it's a little bit more of collaboration. There's not anyone that I'm aware of that's true integration when you look at the model of, especially like Cherokee health system, like Sandy was channeling Perinda just a minute ago. But the other one that's also equally important is Senate Bill 58, which came from the 83rd legislature, which has created a committee, the Behavioral Health Integration Advisory Committee. I happen to be the chair of that. We have all stakeholders represented from managed care organizations to consumers on this. Obviously, we're only going to come up with recommendations. However, these are going to the commissioner of HHSC, Kyle Janik, and to the legislature itself. We're also keeping in touch closely with Senator Nelson's office, which is also extremely involved and wants to see this to be successful. So what we do with the recommendations is going to be very key. The other thing is the committee goes all the way through 2017, so there's a recognition that it's going to take time to make some of these changes that are needed. We're also working with dishes separately and with HHSC to address some things that don't need legislative action, but really it's all done internally just within the administration itself. I think with the pressure of having that recommendation, with senators in the legislature involved in the process, and with the district project out there, I think there's going to be pressure to be able to make those changes that need to happen where the financial model is actually incentivizes the integration of healthcare instead of the disincentives that we have now with the challenges and barriers that currently exist. So those are some positives that actually are happening here in the state of Texas.
So let me turn to our regional partners here and ask you if you have any questions you remember from the lunchtime, pre-lunch discussions that would be helpful to bring here.
Or even comments.
Or comment, sure, sure.
Is it on?
No.
Turn it on.
Yeah, here we go. Okay.
Yes, that's great.
No, we just, when we were having discussions about kind of the goals, the first question about the goals for psychology and integrated healthcare, we talked some about just, I mentioned about psychologists being present and making sure that they are relevant in these changes that go forward. And I'm just curious what y'all might think about folks who are not quite on the bus, and there's some folks that may never get on the bus, but when you're trying to make some changes, especially, in departments where you have faculty who've, had long had their courses and things that they, because I've been there too. What are y'all's thoughts about bringing people along, and just thinking about, because maybe even a faculty department, and thinking about how you can best do that and get people on the bus.
Mm-hmm. Or maybe get them to the bus stop.
All right, I'll talk. I'm not really, I have a bias. I've lived in Amherst, Massachusetts for 35 years and not been an academic. And so it means that I have sat through so many parties of people saying, I can't believe I have to teach 3 courses this semester.
Oh.
And I'm just working my
Don't we know
fingers
it,
to
huh?
the
Don't
bone.
we know it?
And so I have to sort of overcome that bias to try and build partnerships. On the other hand, people from various departments are seeing what's going on. APA doesn't quite know how to get out of its own way in terms of creating more opportunities for training people in primary care, because they have the whole thing of what you have to go through to be an internship, and it's awful. Because I've accredited 2 internships in my career and 1 postdoctoral fellowship. So the idea that Joe Bob Johnson and his partner can bring in somebody for an internship supervised by another psychologist there, and that could work, and we could really move the workforce up, that's a hard one. On the other hand, they're really trying to figure it out. And so I'm getting departments reaching out, and some of them are social work and some of them are psychology, and some of them are using their early adopter status in relation to integrated care for leverage for their own standing in the field. And as that starts to happen, that's powerful, because standing in the field is really what we're fighting for in a lot in academia. And so I think it's hard to hurry it up. You can grump about it, but it's hard to hurry it up. But I also think it's really powerfully happening, just sort of at the back end of the dog.
I really agree with some of the comments about APA and how APA actually presents obstacles. So I think, more things like this conference today have to happen. More departments like this one have to take the charge. But I think there's a view that doing this kind of work isn't really what psychologists do. I mean, I think there's still that bias of what psychologists do is see 6, 7 patients a day for 50 minutes. And I think other professions are rushing in. And I think social workers are much better adapted in terms of their training and their thought process to work in these kind of environments. And so, I think more conferences like this, more departments that actually start changing the reflection of what a psychologist's role is. I think that whole separation that I try to describe briefly is pretty embedded now in psychology, as that we're really not part of the medical system. And we've had issues kind of theoretically about, medical diagnosis, and that we're not really part of that kind of system. We don't do that kind of work. And I think that bias still exists. And so I think we're going to have to find ways to not only educate graduate students differently, but how to educate ourselves differently to remove that kind of bias and realize whether you like it or not, we are going to be part of the medical system. And I think the other way to frame it is we're going to be part of the healthcare system.
Yes, that's it.
Right?
We're health
And
providers.
and divorcing and pushing out will be very self-destructive. And I think if you look at the history of the last 20, 25 years of actually pushing out and saying, we're going to stay separate, the consequence has been diminished enrollment in APA, diminished influence in the field. And I always love what Dave says, our field really is the scientific basis for mental health. And yet other disciplines that take our learnings and adapt them are actually making a lot more progress in terms of integration than we are. So I hope that bias gets moved.
I was just going to say, at the recent APIC conference, which was here in Austin, the Association of Psychology Postdoctoral Internship Centers, Dr. Khatri actually presented with 2 other folks about integrated healthcare and what that looks like in an internship training program, and I thought it was a very effective presentation. And I will also say that APA is, with contingency accreditation, some changing, is hopefully working on that pathway a bit. But so hopefully we'll see some movement in that area.
And I would just add that from a role of philanthropy and also from funding like from HRSA, which obviously is helping to fund this initiative, we'll continue to have an influence. There are a great deal of foundations out there that have a strong interest in our funding integrated healthcare. Hogg Foundation has been funding integrated healthcare since 2006. There are other foundations that have been doing it longer than us, some that are new, but it's increasing in the number of folks that are out there. And one of the discussions we had at our table, which I think was really quite relevant, is also that psychology really needs to start, number one, identify your identity of what it's going to be within the new healthcare system. 2, then actually message it. Messaging and language are extremely important. If you don't get out and say what it is we're going to do and how we're going to play the role in it, how do you expect anyone to sort of understand? We had the discussion of, and I had the question actually posed to me just yesterday. You're a psychiatrist. What's the difference between you and psychology? Isn't that the same? So that question is still happening. We still haven't even addressed that for our society. What about the more complex role that we're talking about here? And yet it must be done, which it really boils down to, especially for those that are in training, is seeing yourself as a leader and realizing you're going to have to be an advocate and get involved with your guild. You need to go out and really partner with and seek out and network with philanthropy and with other, as I like the way Andrew calls it, sponsoring organizations. That's going to be able to make a difference, because I think being able to, like I said, message, but be clear about the message will in fact be very helpful.
Yes.
I have sort of 2 points about the roles of psychology. One is in our discussion group, we talked a lot about just some of the unique skills that psychologists bring to integrated health, and one is program evaluation and just our training and research methods, and program evaluation seems to be particularly important now when we're focusing on quality improvement and monitoring outcomes and things like that. And so we had a discussion about how we could sort of bridge to, on the doctoral student training side, how the folks that are teaching program evaluation courses can sort of help with that and making all of this relevant to practice environments. So I think that's really important. And the other point I wanted to make is I have had the pleasure of being with a program where we've had social work and psychology working really, really well together. And I think it's important to recognize that there's a role for both and that both can work together really well. So what the program that I'm involved in is the obesity, pediatric obesity program. And originally they were looking for a social worker, but I ended up being at the meeting, and so they hired me. And I advocated to have both disciplines involved. And there's some overlap in our roles, but there's also some unique features, and we both have really important training background. So we've worked it out, and I know not everybody has the luxury of having both disciplines, but now with the help of DISRIP, we have an expanded team, and we have 3 psychologists and 2 social workers, and the team is constantly wanting more of us. And I think that we can make the argument that, because behavioral health is such a big part of health concerns, that you kind of need to beef up your behavioral health team and have representation from multiple disciplines, psychiatry as well. So,
Can I?
Sure, you bet.
Just on back to the issue of disciplines. I worry about early closure on what psychologists can do and what social workers can do, and because it is sort of some stereotype from the old days that keeps them from getting into a way of working that wasn't quite what they were trained for. And so one of the things that when I put the slide up of generalist behavioral health clinician, it seems to me that whoever brings those skills is the person who can do it. And to me, it's informative to look at a place like Cherokee who does not care whether it's a social worker or a psychologist who does behavioral health consultant role and who does long-term specialty therapy role. They're absolutely willing to have it be either one, but it has tended to be psychologists in the behavioral health consultant role and social workers in the longer-term therapy role, because that has sort of been the way the skills sets have fit. And so I find that informative, but I don't want to make rules about it. I want to hold to the idea that the people who bring the modules of skills should be the ones who do the work.
Drew, do you have?
I'd just add in our group, we had discussions around a number of the training issues and some of the important areas of developing awareness and skills around practicing in interprofessional teams, the areas of organizational and program development and that sort of thing. And I guess one of the key issues around that, I think that we kind of touched on, was the challenges psychology has with consistency and uniformity in training. So I think we'll probably find that there are well-trained folks out there, but they certainly won't be the majority, and there's a lot of variability. Right now, say at internship level, we have applicants come in every year from many programs. There's a huge variability just on core competencies that they're trained in, let alone getting into more sort of specialty or unique skills and things. So I think I'd just be interested in your thoughts, but as we're putting that message forward and trying to interact with our professional associations and other partners and things of sort of building more consistency and uniformity on the training side.
I would think, and I'm talking a bit off the top of my head, but I would think it is better to have what needs to be, what a person needs to have to do this job, and let the job draw the adjustments of curriculum for people who want to prepare people to do that, as opposed to back in the curriculum committees saying we have to all agree. We have to all agree that from now on we're going to have this thing and that thing and that thing, because the natural tendency is nobody's going to tell me what to do, and we here in Sheboygan do it the Sheboygan way. And so, but I think that the skills involved in doing the job, as the models begin to sift out, is worth articulating. And exactly this kind of a conference and the notes from it and what the work looks like at the exemplar sites, I think is really worth sending out. But we're just at the beginning. The models aren't settled yet, and the competencies are really tentative at this point, and we're still arguing about how much is an individual and how much is organizational. And so I'm not sure I would be ready to commit to a curriculum. When I see you guys' curriculum, I think, wow, you guys have really been thinking about this. This is really amazing that you've got that, but you'd have a hard time selling it to people who are already decided that they're doing it the Sheboygan way.
Let's see if we're on. I just wanted to go back to something that Jane said and tie that in about program evaluation. And that is something that over the last 3 years, I've had to kind of make that segue from research into program evaluation. And when Dr. Martinez talked about, psychology, what's your identity going to be in this new system, I think one of the things we absolutely should market is our ability to, bring so much value to helping to assess outcomes. It's all about outcomes right now. And in doing this work, we find with many of our grant partners, organizations, that there's even, what's the difference between output and outcome? And how can you best capture an outcome, and what kind of measures, and issues of validity and things. And I think what we have to do as psychologists is be willing to do, work on practice-based evidence, meaning, it gets messy out there. You're not going to be able to control this and that, and it's not going to be all, lined up real pretty. But you can add tremendous value to those conversations, and I really think that that's a piece where there's so much opportunity. It's all about evaluation right now, and I really think that that's a piece where we can just jump in.
I'll just concur with with Michelle, because obviously she works at the Hogg Foundation. Not that I'm biased or anything, right? But actually, the development of the evaluation unit, Michelle, has been integral to that at the Hogg. It has really, I think, upped the game for us in the sense of publications have come from that, working with our grantees. Huge role. And the thing is, in philanthropy, there's been a big movement that's been going on for a few years, but it's accelerating, which is actually being able to say, are we having an impact? And to be able to say you have an impact, really it's about evaluation and really taking a hard look at things that did work and things that did not. And this is also the realm of what's happening even at the national level. I happen to be on an Institute of Medicine committee, and one of the things that we're looking at is graduate medical education. Now that's really about physicians, not really about psychologists, the way unfortunately it's defined and the way it's been designed. However, there's never been really any accountability. And now the recommendations that will be coming out within a couple of months will be all about accountability. And to get to that point, you've got to be able to evaluate what we're doing to find out what is actually working and not working, and be able to share that knowledge all among us, add it to the literature and evidence base to determine those that are promising practice, should they become evidence-based practices. To me, that seems like a logical role for psychology to help us to achieve that very goal. That, to me, is extremely important for the upcoming transformation of this healthcare system to know, are we on the right path?
Yeah, I think it's huge in terms of opportunity. I think it moves from, at least the way I learned program evaluation, into large data sets. And I think the whole notion of population management using large data sets and having the skills to do that is going to be really critical, and is already a really highly needed skill in the healthcare system. So, if you're a biostatistician, you have 3 job offers, at a minimum. But I also think we need to get people out there into systems where they actually get experience. So it isn't, I just want to say, it's not just at the practice level. It's really looking at how do you manage populations, and how do we bring the skills that we have in program evaluation to large data sets, and then how do we start making sense there, and how do we place people in a way that they have experience doing that on a practicum or an internship level.
But you have to keep the academics from screwing it up.
That might be the closing comment.
Because they will come in and they will say, well, while we're asking these questions, I have one more dimension I'd like to add, because it would also be good to know this. Well, while we're handing them this, we've got 47 questions here. 50 wouldn't be bad. Let me ask 3 more. Well, actually, now that I look at it, I'm not really sure that this has been totally evaluated as a measure, and so let's take it back and go out for a year and validate it. And when the stuff you're asking, that's not a valid measure, and I don't even want to talk about it. I think one of the most valid outcomes are outcomes that you can say to your patients, and the patients get it right there. And so, for instance, if you ask all of your patients when they come for every visit, how many days of work or school have you missed in the last month due to illness or stress? And make that your outcome, and look at what visiting with your behavioral health person has to do with that, and what coming more often with your diabetes has to do with that. It's a number you can show to the employer, it's a number you can show to the patients, and it's not a validated instrument. But what makes things valid is what we agree is valid. And so we need to be aware of the social contract around validity and put out things that our patients get as valid numbers.
Yeah, we do a fair amount of research, just to your point, on our network. And besides asking a few questions about the facility and, was it private and all of that, kind of boils down to, do you have a good relationship with the person that you're seeing? Are you getting better, or are you getting worse? End of story. That's the program evaluation. And to your point, not a valid instrument. Mm-hmm. It gives us a tremendous amount of information that then we feed back to people. But it can be really pretty simple. And you can get a lot of information in a relatively simple way and find out what's happening in your clinic or in your organization.
Yeah, I was just laughing because part of my job is to be between the researcher and the, grantee organization. And I think that's where logic models, like what are the outcomes? Don't add to, don't let the box completely blow up. Where are we supposed to be going? And evaluation plans, we agree, these are the questions, right? Not 50 more. But I think those are exactly the kind of skills that those bridging skills that students need to have opportunities to learn, okay, this is what you learned about research design, and then this is program evaluation on the ground, and these are exactly the kind of challenge, and communicating and being able to, just like on a care team having different roles, it's the same with evaluation. You need to manage the external evaluator, the grantee, the person who has to collect the data, the person who has to crunch the numbers, and that's a skill set, and I do think creating more opportunities like that is really important.
I'm going to turn this back to Cindy for some final comments, but before I do, I want to thank you for sharing your expertise with us and your time and energy. I know you're all busy people, and to take that time out is very helpful, especially when we are in the early stages of this initiative, and it has so many ways we can shape it, that this kind of advice really does help us channel our energies and keep us from allowing it to kind of get caught out there in the quicksand that can exist in university environments. All right.
Just a quick thank you to everyone for coming, for staying, for talking, for sharing. We will be compiling the notes that were taken from the discussion tables into some logical format and get them all back out to you so that we can keep this community going, hopefully, and all learn from it. And again, I just can't thank you for being here and participating. Again, a special thanks to my GRAs for making it happen and continuing to make it happen all day long and all last night. To the panel, some for flying in and spending unendurable hours in the Dallas airport for however long. But so the regional board for coming together and sharing your thoughts and ideas. You're the ones that are out there doing this, and so it's really helpful to have a closer community to find places for our trainees to go. Of course, all the trainees who are going to be the leaders of the very near future in this area. So thank you to all of you. Safe travels home, and if I could ask my regional board to just stand for a picture before you go, and my trainees for a picture before you go while we have a photographer. And anyone else who wants their picture taken, they're welcome to go. If you don't like the one you have. So thank you. And again, a thank you to our sponsors, ATCIC and the UT Counseling and Mental Health Center. Thanks.